weekend happening on February 19 to 21. And we have had bingo boards that are posted on social media, and the way to get an invitation to this event, as it is invite board and submit it, which is worth $136. And so if you guys were not able to do that and you are still interested in joining us for our mentorship networking event, we are doing a raffle and you can get free entry into our mentorship networking event. So we are opening this up. Right now we are only active on Venmo, but we will be on PayPal for the future sessions. So if you guys do have a Venmo and you guys are interested in putting in $2 to get $136 worth of this event like fundraising fee, since the fundraising dates have ended, you guys can send $2 for a raffle to at pre-health shadowing, and our Venmo is at pre-health shadowing, and you could potentially win a free RSVP to our mentorship networking event. So I will leave this up. If somebody wanted to go ahead and type in the chat for people who are coming late, we can kind of send it every now and then. But we will be announcing this at the end of the session today. So if you guys do want to join us and potentially get a mentor that is, you could have a mentor for life, completely virtual, could be in your potential field of interest, definitely an opportunity for you. All right, we're going to go ahead and get started. So welcome everybody to Pre-Health Shadowing. We are a student-led nonprofit organization focused on making shadowing opportunities readily accessible to pre-health students during the global pandemic that we're currently experiencing. So we are working to make flexible and accessible opportunities, flexible in that all of our shadowing sessions are recorded and can be reviewed at a later time, and still students can take the post-shadowing assessment. And accessible in that our shadowing sessions are 100% free for students anywhere in the world. Anyone who has access to our website is more than welcome to join us for our virtual shadowing sessions to gain insight into their potential healthcare field. All right, just a couple things before we begin. Pre-health shadowing is a way that we can connect students from not only places in the US, but all over the world. So go ahead and drop in the chat where you guys are Zooming from today. We'd love to know. Awesome, welcome everybody. All right, just a couple housekeeping things as you guys drop your locations in the chat. We do send out emails at the beginning of each week that brief you on all of the sessions that we have for that week. We currently are booked every single day until May 31st. So we have shadowing opportunities for you daily. If you're interested in figuring out who is doing what, when, and where, you can figure that out on our email. prehealthshadowing.com/join us is how you get on to our sure that you mark our emails as important. You can also save pre-health shadowing as a contact. By doing this, it just ensures that all of the emails will go directly to your inbox and it'll bypass the spam and the junk and the promotions folder. Just an update for everybody. We have closed captioning for all of our live sessions to accommodate students with hearing disabilities. So part of pre-health shadowing is becoming as accessible as possible for students. And so ensuring that all students, no matter their abilities, are able to achieve their potential healthcare career goals. We have partnered with the woman-led organization Mask for Mask, which is a wonderful org that donates 4 masks for every 4 masks purchased. And these masks are going out to people in need, whether it be a hospital that is lacking in resources or people in the homeless community who do not have the means to provide for themselves during this global pandemic. And so by supporting masks, so if you use the code PHS15, at your purchase, you can get 15% off. And 10% of all of the proceeds that we get through using this code will go to pre-health shadowing to help us keep shadowing opportunities readily accessible and completely free for all of you guys. We have also partnered with Fem Health, who is holding a Purpose Summit, which is a year-long membership with 19 founders, CEOs, and leaders in healthcare. So if you guys are interested in potentially, being a leader within the healthcare field, these are 19 amazing women. Some of them are, the founders of multi-million-dollar companies. One of them even appeared on Shark Tank. So if you guys are interested in potentially networking, learning, gaining some insight from these amazing women, you can check this out. We do have a link in our Instagram bio. It's going to be the 3rd one in our link tree if you guys are interested. Normally this event, the membership is like $50 a year, but with pre-health shadowing, you guys can get this for $29. And also 50% of the proceeds will go back to pre-health shadowing to help us keep free for everybody. All right, here's a great resource for anybody that is about to take the MCAT or planning to take the MCAT, or you don't know if you're going to take the MCAT yet, but you might. We have partnered with Kaplan, so you guys can send us your email and you guys will get free resources and free study guides that you guys can utilize for a bunch of different topics. You'll also get a 10% coupon code to any Kaplan course. So if you guys are interested in getting this perk, this is with pre-health shadowing, there is a link that we'll go ahead and put in the chat, and you guys can click on that, sign up, and you will get the opportunity to have these wonderful resources completely free. We are also having a scholarship opportunity where students can gain a $2,500 course scholarship for Kaplan. If you guys are interested, be sure to be following us on Instagram at Pre-Health Shadowing for updates. Alrighty, if you're interested in getting published, Pre-Health Shadowing is now offering opportunities for students to get their voices out there. You can now submit blog submissions, whether it be an article, a reflection from a virtual shadowing session, or any other situation that you've been in life, reviews of either a shadowing session or our program, or a success story. So if you guys are interested in the opportunity of being published on the official Pre-Health Shadowing website, you guys can check this out. Please note this is only available through the URL. You cannot find this by going onto our website through the menu. So be sure to take note of this if you are interested. Pre-Health Shadowing is starting a podcast, and we do have the organizer of our student podcast here, Anthony. So Anthony, do you want to talk a little bit about, give a brief overview of what you guys are planning on for this podcast?
Yeah, sure. So we'd like to cover all topics that are health related. Some ideas include mental health, possibly talking about food deserts which exist in our country as well as across the world. So if you have any ideas that you'd like to hear on the podcast, please let us know. And if you'd like, please join our team with the link that will be available in the chat.
Wonderful. Thank you so much, Anthony. You guys heard it straight up. If you guys are interested in, being a researcher, finding topics that you're passionate about, networking with other professionals, this is a great opportunity for you. Check out that link. Alrighty, now I invite all of you students here to please pull out your phones. You're going to go onto your cameras and scan this QR code. This QR code is going to take you to a page onto our website, and this page is called the Donate page. So Pre-Health Shadowing, like I said, is a student-based, student-led nonprofit organization where we are making free opportunities for students. But of course, we can't do this alone. We are asking you guys for help. And so please, anything you can, if it's $1, if it's $5, we are equally grateful. If you are financially unable to donate at this time, we more than understand. We are all students. Life is tough. All we ask is that you please share this link with 2 other people that you think will be able to donate. And that will be really helpful for us. It'll be helpful for the students around the world that do not have the opportunities to gain insight into these fields, that have their goal and just cannot reach it because we are in a global pandemic. So thank you guys so much. We really do humbly ask you for anything that you guys can help us provide. And we are really happy that you are joining us on this journey. All right, back to our mentorship networking event. Like I said, this will take place on February 19 to 21. You'll have the opportunity to meet with up to 2 established professionals per day. So as this is a 3-day event, that means you have the chance to meet with up to 6 professionals. And you can not only gain connections with these professionals, but also meet with other like-minded students, potentially people who are on the same path as you. So of course, this is by invite only, and there are only one way to get a invitation to our mentorship networking event, and that will be to enter into our raffle. So if you have not yet done so, you can enter into our raffle. It is $2, and it'll be $2 through this week, and then we'll be moving it up to $3 as time goes. So if you guys are interested in potentially getting a $136 value mentorship network weekend invitation, this is now $2, and you have the chance to win. So you can Venmo us at Pre-Health Shadowing for an opportunity to get in on this mentorship opportunity. If you are interested in helping out, you can help out with pre-health shadowing. We are a student-based organization. We are taking students from all over the world. Whether you are a master's student, an undergraduate student, or even a high schooler, you guys can all help out. You can become a volunteer with pre-health shadowing by be a team member, which is a leadership role where you guys can lead, 3 to 500 volunteers on different projects, kind of gaining insight in the different fields that we might not be familiar with, like marketing, advertising, outreach, grant writing, anything like that. If you guys are interested, definitely check this out. All right, for my high schoolers, if you guys are interested in joining the pre-health shadowing team, we now have a pre-health shadowing high school team. And essentially, they are going to be doing a lot of outreach to like-minded students across the country who will be able to establish pre-health shadowing as a club on their campus. So if you guys are interested in potentially doing this, you can sign up on our website, prehealthshadowing.com/contact/join our team. If you are joining us here today, be sure to post pre-health shadowing on your social media for a chance to get reposted on our official page. So if you guys are interested, go ahead and take a picture of how you are set up for notes today. What is your whole computer setup? How are you taking notes? Let us know, tag us at pre-health shadowing, and we would love to check it out. Alrighty, students can take the post-shadowing assessment at the end of today's virtual shadowing session that will give them a certificate verifying their hours. So I encourage you all to take good notes, and you can ask our professionals some wonderful questions. Feel free to drop those questions in the chat throughout the duration of today's virtual shadowing session, and we will be sure to ask them during the Q&A portion of today's session. And without further ado, I would like to welcome to you our professional for today. He is not only the founder of the MedLife, but also a doctor in emergency medicine. So thank you so much, Dr. Goodkoff. It's wonderful to host you today. Thank you so much for joining us.
Yeah, thank you for having me. I appreciate it. Welcome, everyone. I'm excited to be here. I don't have like a formal presentation. Obviously, I haven't done one of these with you all, but if you know me from social media, you know that I can certainly talk and teach. So we'll do the two of those things today. Nina, are we ready to get started?
Yep, you got the floor.
Excellent. So I don't know if there's a way for me to share my screen. I was going to, I guess to start, I can just talk for a little bit. So my name is Adam Goodkoff. I am a DO, an osteopathic physician in emergency medicine. I'm a resident as well. And I, give me 1 second here. I train in Chicago here. So it's a very busy city. I train at, well, we'll leave the program out of it, but we have multiple sites within the city. So 2 level 1 trauma centers, some low resource areas, and then large academic sites as well. So it's a very diverse program, but I figured I would start with where I kind of started my career back in high school and then take you up through there. And again, if you follow me on Instagram or TikTok, I apologize because you probably know this story already. But so I started out in EMS, actually. I started in the fire side of things because in New York, you actually can't be an EMT until you're 18. And so I really wanted to get involved. I was a lifeguard before all of this, and I kind of enjoyed being a lifeguard, enjoyed the rescue side of things. And so I found out I could do this through the fire department. So I got started in the fire department, and it only took one fire for me to realize that I really did not want anything to do with fires. I think it's terrifying, and bless the men and women that do that, but it's not for me. And so even though there was EMS associated with that, it was not something I wanted to do long-term. So I transitioned over to what was called a CFR in New York. Not a lot of places have this still. It's called a certified first responder. It's basically like a diluted version of the EMT class, but very similar. And so I did that class and got my CFR certification and started volunteering at my local ambulance. And it is a mainly paramedic agency. They don't have many basic providers, which are, so there's in EMS, there's basic and advanced life support providers. So ACLS would be like a paramedic, and then basic would just do like your basic CPR type stuff and things that go along with that, very few med administrations and such. So yeah, I was functioning as a basic at a mostly medic agency. So I really wasn't very helpful, to be honest, but I got to learn a lot, which was the cool thing. I never really had any responsibility as a volunteer because it was a fully paid staffed agency. So I was just an extra there to learn. And I did that for 5 years, all through college and right up until the day I left for med school. I eventually got hired at that organization. Again, I was by the end of college. So I knew at some point, I got my EMT somewhere along the way after I had turned 18, somewhere in college. Um, and I knew that if I was able to put in my time there and build good relationships, that they would probably hire me eventually. They'd done it in the past. There were a couple EMTs that had worked their way up the same path that I did, just volunteering from when they were too young to be there, and then eventually getting hired. And so I knew that that would probably get me hired at some point, but I didn't know with med school and all of that. But ended up getting hired about 4 or 5 months right before I went to medical school, and we'll come back to that shortly. But I ended up getting hired right before that, and had a really nice chance to feel some more responsibility and actually take calls on my own. Just me and a paramedic, and so I would actually get to text some of my own calls and experience that level of responsibility. So that was really nice, and I did that. Went to med school, and I went to medical school in West Virginia. It's a different experience there. I'm obviously not if you are. Unfortunately, I can't see the chat and my screen at the same time, but I spent 5 years there instead of 4. So you might ask why. Well, it's because I chose to do a teaching fellowship. So I stayed and I was a teaching fellow in anatomy and ultrasound. And so that extended me by 1 year. And when I was on campus working, I was actually a faculty member. So it gave me a very nice insight into what it's like to be teaching medicine at the faculty level. And I got to see, be part of the admissions committees and see what they're looking for in students, and, see what makes a good medical student and how to get medical students to the next level. So I went on from there, and that kind of brings us to where we are now. I graduated medical school, became a resident in Chicago, and here we are. So I guess I'll rewind a little bit, because something that I guess would matter a lot to you guys are the pre-med years, obviously. And we'll focus there to start. Something I think everybody should know is that you don't have to be a genius to go to medical school. That doesn't mean that it's not incredibly difficult to go to medical school and to get accepted and to do well, but you don't actually physically have to be that smart. And I always stress that, again, everyone sees me do this on social media. Your intelligence level does not determine your success, especially in medicine. And I think that's important because I had a lot of friends growing up, I guess just had a smart friend group. One of my friends is a PhD that is publishing on a weekly basis at MIT. He's absolutely brilliant. I have other friends in finance. And so I'm not going to say I was stupid. I'm not stupid, but I certainly didn't feel as smart as they were. And I never knew if I would actually be able to be a doctor because I wasn't particularly good at math and school, but I didn't really stand out that much. And so there was kind of always that thought of like, I don't know that I actually could even be a doctor. But I just kind of set my mind to it, and I chipped away slowly. And with every course, that I took in college, I would say, okay, I just need to do the best that I can in this course, and slowly try and improve. And we'll talk about study tips in a little bit here, but it wasn't really until probably. And I went from, being able to get those like high B's, occasional lucky low A, to getting a 4.0 every semester. And there was, obviously a big flip of a switch there with that transition, and carried that on through medical school. So, know that you don't have to be a genius by nature. And honestly, this is something that I tell everybody. Medical school is not hard. It is not academically hard. The volume is ridiculous. The volume is very high. You are going to give up a lot of your freedoms and sacrifice a lot of things that you would like to do in your younger years. But the actual content is not that hard to wrap your head around. It's more just the volume and the speed at which you're seeing it. So remember that, and remember all through this process, there's people that have done this before you. So you can do it too. I think that's important to remember. So real quick, before we go on, I know you guys want to do clinical stuff, but some study tips that I think are really important for everyone to know that get overlooked a lot. My number one tip, and we actually just dropped a study video today on the YouTube, like just an hour ago, going over my algorithm that I use to review questions. I use that algorithm to this day. I'm studying for a board exam right now. And I use that algorithm to review my incorrect questions. So it is that good. It helped me achieve a very high score on step 1, on step 2, and we're going to hope later on level 3 here. So those are the board exams in medicine. So one thing though that I think, in addition to the study algorithm, that propels me and always helps me to succeed on difficult study topics is to convince yourself that you like the material. I realize that's easy to say and easy to sit there and say, yeah, sure, I like the material, but to physically like trick yourself that I'm so interested in learning about this, that I want to know everything that there is about this topic so I can be an expert on this. And if you think about what that means, like inside your head, which is obviously like the majority of test performance and overcoming test anxiety and things, it's a lot of it is in your head and your mindset that you approach these things. So if you approach it, I want to challenge myself and learn everything I can about this because I find this so fascinating. Whatever it is that I'm about to study, I find it so fascinating and I want to know everything there is. You're going to approach that material and kind of consume that material in a different way than if you came at it from a perspective of, I have to learn this because if I don't do well, I'm not going to do well in the final and I'm not going to get into medical school. Or I'm not going to get into my residency that I want, so on and so forth. So that shift in I want to accumulate knowledge versus I want to accumulate high grades will transform your studying forever. And I'm very confident in that. And that's something that I used in my teaching fellowship to help medical students. And it is a dramatic change when you start to shift your mindset like that. So keep that in mind going forward. It's something to try and incorporate into your study routines. Again, if you want more detailed study stuff, check out my social media. Obviously, I do a lot of that there. Again, we just dropped the YouTube video. I have things on my Instagram, and TikTok is always crazy over there. So let's see. We've kind of covered where I came from and some like rough tips. I'm not going to hit on the MCAT much. If you have specific MCAT questions or you're looking for like a tutor to guide you through the process, one of my friends has hands down the best MCAT program that I have ever seen. I'm really proud of what he came up with, and he's killing the game, so to speak. He is absolutely dominating the MCAT market, and his students just destroy the MCAT. So if you are looking for extra help, I admittedly am not the expert in that anymore. I don't do, it's been a long time since I took that test. So if you do want help in that area, you can send me a message on Instagram and I can get you in contact with the other Adam, who is the MCAT expert. So we'll kind of leave MCAT at that because I don't have a ton of helpful information on that. So I was going to try something. I was going to try and screen share for you all to talk about, like, we usually do. And I don't know, again, I can't see the chat, but I don't know. And sorry, I do live in a city, so you guys will hear whatever else people. Melanie, no, definitely not. This is Adam Nassim. So he is my friend. I got the chat open here. He's one of my friends. He's you'll find him as like a verified profile on Instagram. He's really incredible dude, doing good stuff. So I'm gonna try. If you've seen my live simulation sessions, that's what this whole setup is for on YouTube that we do. They're fantastic, and we actually, this is a little piece of leaked information here. Follow me obviously across everything. We have our own app that is coming out. Sorry, I can hear it through the headphones. I know the fire trucks can be loud here, but we have our own app that we designed with the app that I'm going to show you here. Hopefully, if this works, and it's going to have live polling. There will be additional drugs that we can give, intubation, so all sorts of cool improvements. It's coming out very soon, so stay tuned for that. It's going to be absolutely free to download, and every time I go live, you'll connect directly to. You're not able to make the stream on YouTube, you'll be able to see it here. So like on your own iPad. So let me see. So it gives me an option. Let's try this and see what happens. Oh, excellent. It kind of works. Can you guys see this?
Yeah, yes, I can.
Oh, excellent. Okay. Let me get some things cleaned up on my screen, like fix the chat so that it's not blocking everything.
We're just
Okay.
supposed to be seeing some basic vitals, correct?
Exactly. Yep. Just the monitor here. So this will be I just kind of figured it would be fun to walk everyone through what we're looking at on our monitor, some of the basics. Everybody, of course, is going to be at different places in their career with interpreting vital signs and so on. I guess I can't turn that volume down. Yeah, I don't think I can. So we'll just have to listen to that. You get a taste of what my life is like every day in the ER. But so let's walk through this, and we'll kind of take a look at the monitor as a whole here. So we have our heart rate is up here. We have a rhythm strip, our oxygen saturation, and we're not going to worry about this for this session or this. We can maybe talk about this a little bit later. And then we have some blank numbers down here. Oh, I realized you can't see I wonder if you can see, there we go. Okay, it's kind of like a pointer. So down here we have some blank numbers just to go over what I just did. Heart rate is up here. We have our oxygen saturation, and then some blank numbers, which will require a blood pressure, which unfortunately it's gonna make noise, and I have no way to turn that volume down. So we'll just let it do its thing. Give it a minute. All right, so it's done. We won't hit that button again, and unfortunately, oh, can you guys hear the volume or no on this through this app?
No.
Oh, that's fantastic then. So I'm the only one that has to listen to it. This is even better. So anyway, so we have a blood pressure now we can see. So let's go when I walk in a patient room and what you can start to do. I remember someone taught me this as a pre-med student. I thought it was so cool. So, and feel free to unmute yourselves unless that's against the rules for this, because I'll kind of ask questions. I think it's better with participation. But what would you guys call this whole? I kind of hinted at it earlier, but this whole top line, what is this? We're only looking at one lead, obviously. Does anyone know what that's called?
The heart rate.
Heart rate's to the right. Yep, that's true. But this has kind of a name for it. It's not an EKG, a rhythm strip. Exactly. Yeah, this is a rhythm strip. So you can see we have a rhythm strip. This is a subset of an EKG. So we have leads on a patient. They're monitoring the electrical activity in the heart. As the electrical impulses travel across the heart, electrodes placed on the surface of the chest are picking up those impulses as positive or negative deflections. So towards or away from those leads that are on the chest. We call them leads. So this would be one single lead that we could select to look at. So the first thing we do is just take a quick look, and just visually, I can tell you this is not a fast rhythm. It's it's about normal. And then of course we have the number to confirm that. So we go through and we look. Does anyone know what this first wave here is called? It's going to move in a sec, but this one right here.
Said the P wave.
Yeah, it's a P wave, exactly. So P wave is represents our atrium or the top of our heart. How about here?
QRS complex.
QRS complex, very good. QRS represents the bottom of our heart. That's our ventricles. And then here we have, does anyone know that? No one?
T wave?
It's a T wave.
The
ST. Yeah, it's a T wave, exactly. T wave is important for a lot of reasons. It's a repolarization in the heart, specifically the ventricles. But what's important is it helps us to define this segment here that I keep highlighting. So between our QRS complex and our T wave, we have something called the ST segment. So that's right here, this space in between here. And there are ways, and I'll just show you, like you can see the back end. Usually during our sims, this is kind of nice because the users don't see the back end. But I'll show you just, for example, STEMI is what everyone talks about in EMS and things. And so I'll show you what happens. We can see that ST segment. So there's our QRS, but that ST segment is now elevated off of the baseline of our rhythm. There's kind of this gap here. And again, you would need an EKG to really look at this, but it's changed. It's elevated. It doesn't look normal. So that can be a sign of ischemia or a heart attack. And that's something we do look for in every EKG that I review. So we'll kind of put it back for now and look at the rest of our stuff. But yeah, so that's kind of something cool that you can take away if you ever see that in a very severe form. It's called tombstoning. It's much higher, closer towards, so that ST segment will actually come up and be flat right around here. That's a very, very poor prognostic indicator. That means that there is absolutely some ischemia going on. So coming down, this is a waveform. We're not going to go over the specifics of a waveform, but it is important to know that you want to see something similar to this, kind of a consistent up and down flow for your oxygenation waveform. If you don't see a good waveform, the number over here really isn't going to mean much. 98% is normal. Anything really greater than 94% is normal. It varies person to person. Under 93, we start to think we maybe need to put some oxygen on. So these are the things that we're looking at. We've come in, we've looked at the heart rate, we took a quick look at the rhythm, looks regular, don't see anything crazy going on. Take a look, we have a good waveform, so we can trust our number, it's 100%. And then we skip down and take a look at their blood pressure. Their blood pressure is, basically normal. 120 on 80 is the textbook answer for normal, although new guidelines are actually recommending blood pressures be a little bit lower than that. So it looks like somebody's drawing on our thing. So there you go. That's kind of how, and then we can look down here. We have a respiratory rate. Does anyone know, would you call that normal, slow, fast?
I would say normal.
Normal. Yeah. It's pretty normal. I don't know who's drawing or how they're doing that, but we'll avoid that. It's pretty normal. It's on the slower end, but it's nothing to be concerned about, especially since this patient has a low heart rate. They're probably relaxed. So that's kind of like a quick overview. I'm going to show you just so you've seen them while we're here, because it's easy to do. I'll show you a couple other rhythms that are very common that you'll kind of want to know about. So this is one that absolutely is bad. So can anybody tell me, do you see P waves here?
No.
I don't think I see any. No.
Barely.
Yeah, no, there's no P waves, right? This is totally irregular. So there's no regularity here. We see some wider complexes, some really wide complexes, some more narrow ones over here. So this is all out of whack. And because it's kind of going all over with no regularity, we call this VFib, or ventricular fibrillation. To fibrillate is literally just to spasm. So this is like the ventricle is spasming here. This doesn't move any blood, and so this is a lethal rhythm that needs to be shocked. Next one we'll pull up. Obviously, you can see it's going to be ventricular tachycardia. You see how different that is? This is wide and regular and fast. So if you see something that's wide and regular and fast, again, there's no P waves. There's nothing that we saw on those original EKG or rhythm strips. This is concerning. This would be concerning. The things we need to ask if you ever see this are, do they have a pulse or do they not have a pulse? So patients who have this who don't have a pulse, they need a shock. Patients who have this who do have a pulse still need a shock, but it's a synchronized shock, and it's a discussion for different. If you're interested in learning more about that, come to our YouTube lives. We talk about this stuff all the time. So just so you've seen it and you recognize this rhythm. Now, I will kind of, let me see, figure out how to end this. Go do that. Okay, so I'm back. So those are just some basic rhythms that really everybody should be familiar looking at, and it's totally understandable if you've never seen them. Now you have. Does anybody know? I'm going to ask. Has anyone ever had the opportunity to do CPR? You can unmute, or you can put it in the chat.
Yes.
Okay, so it sounds like some people have had some exposure to doing CPR. So were you doing CPR? I guess it's going to be too hard to ask everyone, but so I'll just kind of say it, I guess. So there's ACLS, which is the advanced. I talked earlier about paramedics and doctors and in hospital. There's that side of resuscitation, and we look at the rhythm and decide what's going to happen. But if you've ever been in a setting as an outpatient where you took an AED out of one of those emergency boxes, or you are a basic ambulance, something like that, you have something in your car, that's all basic life skills. Those AEDs, you don't see the rhythm. So it's good that you recognize those, but you actually don't have to make a decision. The AED will analyze and decide for you. So you'll only see that when the patient is on a monitor where someone is doing advanced life support. And I actually see the chat is kind of open side by side. Someone was asking, what is the app? So the app will be called, I think we're calling it the MedLife simulation. We literally just finished up the last version of the beta. It's going to be called if you search the MedLife in the App Store, when it goes live, again, follow my Instagram for the official go live date, because we We have one final tweak. The app that I was just using is called Simple Patient Monitor. That one, though, is not going to have nearly as many features as the one we're launching. And of course, it's not going to have the live sim and live polling. So I'll be able to put out questions and you guys will be able to answer them live time. I don't know if that would count for shadowing, and we can talk about how that might work later on, but it is on YouTube and we stream totally free. So, those are two kind of cool rhythms. Yeah. And I see, I'm glad you guys are liking that. Just keep it a secret in the chat for a couple more days. It's just for you guys to know here. We're really excited about that. We've been working hard. So those are some rhythms. I think maybe some like medical side of things for you guys. Honestly, I think I'd rather do some question and answer and be able to give some like directed advice or, answer some questions, talk about things you guys would rather talk about rather than me kind of just blab on. I don't know, Nina, if you open it up or how it would go from here.
Host Aster Castro will be answering the questions that were dropped in the chat, or asking the questions, excuse me, that were dropped in the chat. And then for all of the students that are interested in communicating their questions directly to our professional today, feel free to utilize the raise hand function through Zoom. You can find this by clicking on reactions, and through that you'll be able to see a series of little emojis that you can click, and also the raise hand function. Of course, if your Zoom is not updated, you may not have this. No worries, feel free to drop your question in the chat and we'll be sure to ask it orally. Thank you so much. Go ahead, Aster.
Yeah, sure. Okay, thank you so much for giving me that presentation. That was really interactive and something we haven't had on here before, so I think that was really cool. One of the first questions that somebody had was, what motivated you to choose emergency medicine as your specialty versus all other specialties?
Yeah, that's a great question. So number one, I have a habit of saying that's a great question, so everyone knows and can chuckle now. It's I'm working on breaking it, but it really is a good question because medical school gives you such a wide variety in your education, and you are never, unless you have a really good mentor, nobody really ever sits down and says, "Hey, you have to decide what you want to do." You're so wrapped up in doing well on your exams. And again, if you think back to what I said, it's not about doing well on your exams. It's about learning as much as you can, because someday you're going to need to apply that information. And so you're spending all this time learning and you're trying to get involved with student groups, but really you don't have that much time. And you're not getting out on rotations until third year, and really like quarter of the way, halfway through third year of medical school, people are starting to say, you need to decide what you want to apply for next year. And so you don't have a lot of time. And so for me, I always, I always loved emergency medicine. I did EMS for so long. I knew what I was getting into. I had friends from doing EMS. I had met doctors there and had mentors and things that, I could say, what's this like? And, so on and so forth. Do you like your life? How much do you make? Those kind of things. Kind of the ins and outs. And so I knew that it was something I wanted to do. The only thing that even like sort of interested me, to be honest, was anesthesia. I'm a huge procedure guy. I love doing procedures. I find them the most rewarding. There's a big difference, which again, I'm trying to, put myself in your shoes. When I was a pre-med, I actually ran a pre-med group at my undergrad university. And so, I feel like it's sometimes hard for me to bridge the gap and think like what level I was at then. But so surgeons do procedures, but they do surgery, and the procedures is like a catch-all term. So that could be an intubation, that could be a central line, that could be suturing, it could be placing an art line, any of those things. So like, for example, a surgeon could place a central line, but a surgeon cannot intubate someone. And every specialty has different procedures that they do. So emergency medicine doctors can do lumbar punctures and intubations and central lines and art lines, but it would be inappropriate for me to do an epidural. Whereas an anesthesiologist could do all of those procedures, and an epidural and a spinal and, a little bit more in that area. But an anesthesiologist would not be able to do casting. They wouldn't be able to do a shoulder reduction. Those would be out of their scope. So you have to kind of decide, what is it that you like to do the most and what is your focus? And I liked the anesthesia rotation that I did a lot, because I did like some astronomical 40 or 50 intubations during this whole rotation. So it was a really good experience. But at the end of the day, I sat down and I was like, what do I want to do the rest of my life? Do I want to sit in an operating room, cold, behind the curtain, having surgeons that have personality issues yelling all day? No, that's not what I want. And I encourage anyone that wants to be a surgeon to break that culture. Unfortunately, I've yet to see it very much. I have some friends that are surgery residents. Obviously, people you're close with, they treat you better, but there's still just a ton of just ridiculous behavior that I see on a regular basis from surgery. And so I knew that wasn't something that I wanted to deal with long term. And I also didn't find running cases long term versus seeing a lot of people dealing with the really sick patients, getting to do all these procedures and so on. So ultimately, that's why I decided on emergency medicine. The lifestyle is very good. The residency is not too bad to get through. And it gives you a lot of opportunity down the road. So I hope that answers your question.
Yes, thank you. Danielle, if you would like to go ahead and ask your question, you can unmute.
I was wondering how you deal with like burnout in emergency medicine. I think it's like the highest specialty of burnout. So have you ever experienced it, or do you know anyone else that has?
Yeah, it is one of the highest specialties or one of the highest burnout rates in medicine. I can tell you a little bit about why. And I can tell you, I absolutely have experienced burnout. I've experienced burnout in medical school, in residency already. It is a normal phenomenon. I'm sure everybody in this room has experienced burnout at some point. If you've ever been laying in your bed and thought, I physically can't will my body to get up right now. I need to stay on my phone a little bit longer. I need to put on another episode of Netflix. That is burnout. And the more that people talk about it and normalize it as a behavior and a feeling that we just have as part of our life and how we deal with it, that makes it all better. Kind of labeling it as this like stigma of like, oh, geez, you've had burnout, like that. Cause that's how, when it first came out, I was like, well, if you have burnout, your career is probably over. And it's not true. It's not true at all. And sometimes you just need a good vent session with a colleague. Sometimes you need to just take the day off and not study and not do any other work. And sometimes you need professional help. There's varying degrees of it. So absolutely, there are weeks where I'm just like, I physically don't want to go into work. I am so exhausted. I just need a day to myself. And that's okay. You need to, at least in my opinion, I guess I'm not a burnout expert, but in my opinion, what keeps me going is recognizing that, looking inside and saying, right now, I'm not good. Like I need to take some time and de-stress and get myself back to a level baseline. And then I can go be the best for my, so I think that's my experience and how I've dealt with it. Why is it so prevalent in emergency medicine? A lot of reasons. The biggest reasons I would say, number one, unrealistic demands on physicians. So you are expected to see, as an attending, 2.5 patients per hour, which in your head is like, yeah, sure. I mean, especially like once you start doing medicine, you're like, yeah, I can talk to patients really quickly. I can put orders in, I can write notes. That's no problem. But then you realize that you stop picking up patients an hour before the end of your shift, and that number is divided out over your whole shift. So now you have an extra 2.5 patients to spread out over your other hours. And that doesn't count the patients that require a procedure. So if you go in and do a central line, that's probably 30 minutes realistically by the time you've got everything set up and performed and post-procedure x-ray. So now you just knocked out 30 minutes. Now you're another patient behind. So now you have to see 4 patients in the next hour in order to still get done on time. And you have all of your notes and all of your admissions to call and all of these things. So there's a large, then from the other side, from the patient side, what can be frustrating is patients will come in with unrealistic expectations. It's not their fault, but it's part of what we do. We try to set expectations, and it can be very stressful when you do. We rule out emergencies, and this is something I can talk about if people are interested, but the mindset of emergency medicine is not like any other practice in medicine. And that's actually another thing that attracted me to it. Like, we don't make diagnoses. That is not my goal. I discharge people without a diagnosis all the time. My goal is to make sure that you do not have a life-threatening diagnosis that will kill you within the next 24 hours. And that's very, very different than, going to your primary care doctor who says, yes, it sounds like you do have reflux disease. I need to send you to a gastroenterologist. I want to get this test. And that is chasing down what you might have. Whereas I would take an x-ray and say, there's no free air in your diaphragm. You have not perforated your esophagus. You can go home. I mean, it's more complicated than that, but you can see it's a very different approach to taking care of that patient. It doesn't mean we care less. It just means that we're focused on a different. So what can be very stressful is patients coming in with non-emergent conditions, having negative workups, and then basically just having a negative outlook on the care that you provide, or basically not being willing to listen to kind of why you've done what you've done and why you think it's safe for them to go. A lot of people come to the ER because they want to know what's wrong with them and they want a pill to fix it. And that's not something that we can do. And so when you add up all the other things that I was describing and you put that on top, it can really wear you down. And so you have to find ways to manage that and, find ways to kind of meet patients in the middle. So.
Thank you. I think that was a really interesting perspective, and it just kind of goes to show that medicine isn't all about like the scientific stuff behind it, but also your social skills and your ability to communicate and deal with difficult people. Michelle, would you like to ask your question? I hope I said your name right.
Yes, yeah. I would like to know, what's the main difference between a MD and a DO?
Yeah, so clinically nothing, at least in emergency medicine, nothing, surgery, nothing, PM&R, and probably family medicine. And that is that we technically approach patients differently. And I don't disagree with that. The way that we learn to approach the patient is very holistically. And, how is the patient going to do at home with this injury and what type of support will they need? And so the approach of getting to the diagnosis can be a little bit different. Some people say it's more patient-centered. I hate using that term because it alienates my MD colleagues. And I have a lot of friends and fellow physicians who are fantastic, humanistic people who are MDs. And so on the flip side, I know of DOs that are incredibly awkward and not great with patients. So I don't think that a title defines who you are. I think you define who you are, and what you do, your actions define who you are. So fundamentally, in our practice, there is no difference in MD or DO. There are a few of us that are DOs in my program, but it is a historically MD program at a large university, and nobody knows the wiser. Nobody questions anyone on their degree or their knowledge level. So clinically, there's no difference at all. Unfortunately, there's still stigma, obviously, when you're applying for medical school and then when you're applying for residency. I had a couple programs that flat out said, your application is far, but we're not interested in taking a DO. And they had no reason why. But they just didn't want to have a DO on their staff. They felt that they were too prestigious to have a non-MD title on their staff. And I had another, we'll leave it unnamed because I liked some of the faculty there, another very famous emergency medicine program that told me they wanted me to come to their program because they were looking for diversity. And I'm sure you can see, I mean, the light is pretty bright, but I'm a pretty white guy, just a standard white guy. I'm not that diverse. You got to own your strengths and weaknesses in life. And, I wanted to come to a program that was very diverse so I could grow as a person. But in myself, I'm a white guy. I grew up in, upper middle class. So I'm like sitting there in this interview and I'm like, what could they possibly like, either they're confused. I just don't understand what's going on. She goes, yeah, we're looking to improve our diversity by adding a DO. And I was like, so incredibly offended. I was like, I bring all of this information to the table, like all of the stuff that I've worked for. I'm a first author on an ultrasound paper that changed curriculum in the DO world. I, have all these incredible letters from big time universities that I've rotated at as a medical student. And the reason you want me is because I'm diverse by being a DO. And so unfortunately that still exists. I think it's going away. It's going away more and more. And shout out to almost every big doctor that you follow on social media is a DO. Dr. Mike is a DO. Myself, DO. Dr. Salini, DO. I mean, the list goes on and on and on. The majority of the doctors, if you are a FIGS fan and you wear FIGS, the majority of their collaborators are DO physicians. So, so it looks like Lauren's saying she didn't even know I was a DO. Yeah. And to be honest, I don't put it out in the open because I think it sets you up for the chance to have bias, especially working in a system that is predominantly MD. I don't hide that. I'm proud of what I am, but I think anytime that you can It doesn't detract by calling myself Dr. Adam Goodkoff on my scrubs versus having Adam Goodkoff, DO. And so I feel like it's easier for patients. It's easier for staff. Everybody's just on the same playing field. And so that kind of is a very long-winded answer to your question. If you want to get down to it specifically, we can add the OMT, like I said, for DOs.
Okay, thank you very much.
Thank you. Joseph, would you like to go ahead and ask your question?
Sure. So without like breaching HIPAA, what are some of the more notable like cases that you've had presented to you in the emergency room?
That's a really good question. I'll do the best I can. So these get tricky, especially since the meetings are recorded. And I mean, it's like public knowledge where I work for people that it's one of the biggest questions I get on social media all the time, which I don't openly answer it, but like every physician in the United States is registered where they work. It's how it works by getting an NPI number to prescribe medication. So it's not secret. So I have to kind of be careful what I share, especially with kind of the unique cases. But I will say one thing I'm very passionate about, and this was the same even with OMT, is I don't personally use manipulation therapy that we learn in DO school, but some physicians do. Manipulation therapy is different than what a chiropractor does. Plain and simple. I have seen multiple vertebral artery dissections from chiropractors. Artery runs up through these foramen, small holes in your cervical spine, all the way up to your head, and it supplies the blood to your brain, like the majority of the blood. And so if you go, well, I guess not the majority, but to the backside, and if you take someone's head and rotate it very quickly and put shearing force on those small foramen, you're going to run the risk of tearing that artery. And if you tear that artery, you can either dissect, you can form a clot and throw that clot off. And the point is either way, you're going to have a stroke. And so you're going to be a 25-year-old patient who has a stroke and now has permanent left-sided weakness and can't talk. So I am super openly anti-neck manipulation. I'm not anti-chiropractic. I think they do other treatments that seem to work for them. Everyone has a different approach. They do some things that are similar to what physical therapists do. So in the right setting with the appropriate safe application, it's fine. But the neck cracking stuff is insane to me. I think truly it has no place, very, very limited benefit from it. We learn about manipulation as well. And I just think there was actually, and this blows my mind, our school had stopped teaching manipulation of the cervical spine because there was a student who dissected another student's vertebral artery. So again, this is like not a rare thing. I mean, it should be rare, but it's like more and more common. And you see so many people going to chiropractors for neck cracking. So please don't. That's my PSA. And seriously, if there's one thing you don't want in life, it would be to have a stroke with long-lasting deficit. Seriously, it's sad stuff. So that would be one like pretty, textbook rare case that I saw very recently. That was pretty crazy. I mean, I'm in Chicago, so you can imagine the trauma that I see is worse than what you see in movies or on TV. It's real. The names that you've heard for Chicago are real. 2 weeks ago, I was going to see a patient and like a giant steak knife fell out of their pocket. I was like, come on, man. What are you doing with that in here? Some other guy a couple weeks ago, a gun fell out of their pocket. So it's a very violent city and we see a lot of trauma as well, unfortunately. So we'll probably leave it at that. But I think that's a pretty good story of like kind of a, zebra type case. That's pretty interesting.
Thank you. Ari, would you like to ask your question?
Sure. Hi. So you mentioned you worked in EMS through college, and my question is, how did you manage as an EMT while attending your college classes?
Yeah. So I'm like a little non-traditional in a lot of the ways I kind of do things. And I don't personally think college is that helpful. It's not a popular opinion by a lot of people. I don't think college is helpful for medical school, aside from your basic, like the prereqs are literally what you need. And when students ask me, and I was actually interviewed in a US News and World or something about this, like I sat on an interview committee and I interviewed students, and I did it as a med student in like kind of the secret way where you have lunch with them. And then I was actually an interviewer when I was faculty. like being a biology major is great. I did it. Everybody does it. It's fine. There's nothing wrong with going that route. But if you can walk into a room as like a marketing major and be like, hey, I have such a deep understanding of how healthcare marketing works, and here's some really cool stuff, and here's how I want to change medicine, and I'm so excited to be at your program, I would have thought that interview would be so much more interesting. So nobody has to run out now and change their major to like arts and sciences. But if you are passionate about something else, don't shy away from that. And take those courses. And what I'm getting at is, I was passionate about EMS. I was not passionate about anatomy of chordates. And so I took the very minimum that I could in the biology and the chemistry and all. I basically got the credits that I needed to graduate with a biology degree. And then, the prereq courses. And then for my other classes, I honestly took things that were like easy or fun. And what that did was gave me less stress and less workload to allow me to do things like get my EMT. That was one of the harder things when I think like look back, especially on time commitment. Like it was far from where I went to school. I had to drive like 40 minutes twice a week. It was a big time commitment. But when you want something bad enough, I'm sure you've all experienced this, you find a way to do it. And I really wanted to be an EMT. I wanted to take it to that next level. And so I did. And I don't think there's an easy answer for that. But if I think it's important, because I want to share that if you have something else that you're passionate about, whether that's being an EMT or being a poet or whatever it is, do it and get your prereqs done and have a fantastic GPA in those, but also do something else at the same time, because this is like your one chance. And that's something so many people miss out on, is that you're like, it's something that I missed out on and I'm discovering now, is like I went straight from high school to college to medical school to residency, like on, except for the fellowship year. And it's like, along the way, you start to realize like, whoa, I have other interests. Like there are other things that I might have wanted to do in this life. And I love what I'm doing, but I also kind of want to explore these things. And I think if I let myself wander a little bit more in college and take some more of those, maybe I took a business class just to see like, what is business? Like, what does that word even mean? I always used to like make fun of the business student kids, because I'm like, business, like, what are you going to learn in a business class? And now I'm like, be kind of cool actually to like learn business. I know nothing about business, or like if everyone's been watching Wall Street, I know nothing about finance. I've been learning on my own. So do cool things while you're young, and it will make you a more well-rounded person.
Thank you. I think that's really good advice, because you hear there's a lot of pressure. I'm so involved in all of this stuff, and you know what? We're young and we have time to do other things. We'll take one more question verbally, and then we'll get into some of the ones that have been put in the chat, just so we can get to everybody. Jennifer, would you like to ask your question?
Yes, hi, Dr. Goodkoff. Thank you so much for doing this with us. First of all, I want to say about the neck cracking thing. I didn't even know that, so whoa, like I won't do that. But also, I wanted to ask, so I applied to medical school this round. I did so a little late because I took my MCAT kind of late. And I haven't gotten any like responses back yet. And I know that you mentioned that you were on admissions committees before. So I wanted to know if you could maybe discuss what admission committees look for. I know like kind of the basic like MCAT score, GPA, but I'm trying to figure out like what I need to do with my application to just be more, I don't know, just stand out more and, things of that nature.
Yeah, no, I hear you there. I'll tell you that there's no magic, and there are certainly, I've gotten in many arguments. So I can be a polarizing person. I have very strong opinions, and I don't agree with a lot of what admissions committees look for. They're using old data, and I'm the perfect example. I had a pretty poor MCAT score, I guess. I took the old MCAT, so I don't know what it converts to. It's like in the low 500s. It wasn't anything that like was, like would get you automatically accepted. And that was the main problem with my application. But if you look at the data that they're using statistically, I should have performed very poorly on my step 1 and had a very hard time getting residency. And I destroyed step 1 and step 2 and had wherever I wanted to go for residency, essentially. And then again, it kind of solidifies what I was saying. Like, be an interesting person, do things that you love, and don't worry so much about the process. I know it's easy to stress like it's easy because I'm on the other side and now I'm called doctor, but like not that long ago, it's where you were. And I remember like, all I want to do is get into med school. It's all I need to do. And then once I do that, then I can do, and like at some point I remember saying, and I would tell people this as a teaching fellow, like I used to like do whatever I had to do, just like you guys do. So someone's like, do you like, helping the homeless on the weekend in the food kitchen? I'd be like, absolutely. I don't like hanging out with my friends. I love doing that. It's like, you say that. Why wouldn't you say that, right? Like you're sitting here looking at your future and they're like, do you think that's something you'd like to do? Yes, of course I'd like to do that. Like no one's going to say no. But at some point, and this is like, maybe it comes with part success and part like age and wisdom. Like I stopped saying that. I was like, no, it's not something that I'm interested in. Here's what I am interested in. Here's what I'm passionate in. And so I think it's so hard to do this. And I wouldn't say like give up all the traditional stuff, but if there's something that you are really passionate about, go do that and be really good at that and bring that to the committee. And then you can say, if you're truly loving what you're doing and you are so passionate about it and you go to a committee and they're not impressed, then you can say back, this isn't the fit for me. I don't want to come to your program because you and we don't vibe. Like what I'm passionate about is not what your school is passionate about. And it's easy for me to sit on the other side and say that. But like, if that's truly something that you've developed as a passion and you're not just going through the motions to get into medical school, then you're going to be butting heads with the people in that university. Or let's say you love international medicine and you go to a program and you're like, oh, I've done this, this, and this, and I want to set up this and I've secured these donations. What do you do? And they're like, well, we have one trip a year, but only the seniors go. Well, that's probably not the place for you, And just remember, there's so many. Hope you do keep your options open and apply osteopathic and allopathic because you still have plenty of, barring being like a neurosurgeon at Harvard, you're going to be fine as a DO if that's something that you were worried about. But so I think that's the number one thing is be true to yourself. Don't try and fit the mold because everyone else out there is fitting the mold. Everyone is doing it. And the, part of the other thing is its numbers. Its numbers. Everyone here knows its numbers. You do need to have some kind of minimum value numbers. And that's what I've gotten in some really big arguments, what I was getting at when I was on the board and they didn't really like having me because I would just tell them how ridiculous they were with their numbers because I was there for you have a finite time that you're supposed to be in medical school. And if you are there for 5 years, that's too much exposure. So I saw a lot of classes go through medical school. I saw a lot of different types of students and different people, and smart people don't make good people and so on down the list. Like there's not a checkbox. It has to be a personal thing. And I think DO schools are better at weeding that out. But again, I think it goes back to being passionate. Find something you're passionate about, be the good person that I'm sure you are, and somebody is going to see that. And you do have to be realistic. You may need to retake your MCAT. You may need to do a post-bac, whatever it is to get those numbers to what is minimum necessary. Because nobody, and I promise you, this has happened to me when I applied to medical school, even if you have a personal connection, nobody's going to waive they're going to have a number in their head. And if the number's below that, they will not interview you. And that happened to me with my hometown school. I had this guy and he was the director of admissions and multiple times, oh, we're looking for your application, whatever. I told him what my score was, no problem. I applied. All of a sudden, whoa, this year we're not taking that score. Why don't you just retake the test? We'll send you an interview. And I was like, no, I'm good.
Thank you.
Yeah, you're welcome.
Thank you. Yes. I'm sorry, your screen just says iPad, but you've had your hand up for a while, so I want to let you go ahead and ask your question.
I'm assuming you're talking about me. So I'm learning about a lot of like healthcare policies, and it's become to it's came to my knowledge that a lot of Latinx community go to the ER because they don't have insurance. And so they can't consistently go to clinics and get their monthly checkup. So even though you're not involved in healthcare policy, how could people tackle that issue? Because I think that doctors and I think that like PAs and nurses do have a good grip in the sense of like how insurance companies work. And so what advice could you give companies or insurance companies or to the general public about what you think could be done better?
So to be honest, if I had the answer, I would also have a Nobel Peace Prize.
Oh, okay.
There is no one, that is the hardest question that you could ask anyone in healthcare. And I think if there was one right answer, we'd have it. Some people would argue a public health system where everyone has free access to care makes sense. And I think it does, for the record. I think that people should have health insurance. It's not acceptable for people not to. But that's the system we live in. And part of it is health literacy and, education about things. And I agree. I do seeing a lot of the Spanish speaking patients in the ER. I volunteer to see them because it is so much easier to speak the language that someone speaks. And honestly, the translators are often wrong in what you're saying. So I hear you. I rotated it somewhere, one of the program outside of New York City, which was almost 100% Latinx population, very underserved, very low socioeconomic status, a lot of crime and very little education. And I felt the same way. I had the same questions, and I don't think there's an answer. I mean, free clinics help, but free clinics have to be funded from somewhere, and, low cost primary care options and so on and so forth. But ultimately, it boils down to hours, and a lot of it is finance. But if the clinic's not open, they don't have anywhere to go. They have a question, they're going to come to the ER. And I wish I had more for you on this answer. I think it's somewhere that we need to do a lot better. And I certainly don't have the solution as of yet. But I think bringing attention to it, education, and then, trying to get people insurance or get them with some type of a clinic or long-term provider. Because like you mentioned, coming to the ER for those health problems, we are happy to see people and happy to, try and help out. But if someone's coming for blood pressure refill on their medication, not only is it inappropriate for me to do that, but it's also unsafe because I'm not going to have follow-up with that patient.
Thank you.
Yeah.
Okay, Vivian, you can go ahead and ask the last question out loud, and then we'll get to some of the ones that were in the chat.
Hi, Dr. Goodkoff. Thank you so much for doing this presentation. It was really inspiring. I wanted to ask, for our college medical students, I wanted to know if it's a good idea to do phlebotomy certification before I head off to medical school so that I have at least a basic knowledge before we have to be poking other medical students as well.
Sure. So you actually don't, you kind of have to look for the opportunity to do IVs as a med student and as a doctor. We don't do them that often. And emergency medicine is an exception. We do ultrasound guided IVs all the time. It's one of the things that we're called to do very often. Us in anesthesia, again, procedure pros, get to do that stuff a lot. But I think if it's something that you enjoy and you think you either A, want to hustle a little and make some cash before going, great idea. Or B, if you like doing that and you want to get good at that, that could be a really useful skill set. I will tell you, drawing blood is different than starting an IV and draw blood in medicine. Like, we'll send patients to an outpatient clinic for that, but you really wouldn't be there. And so that's kind of done with like a rigid metal needle versus doing an IV where you're, have a needle, a catheter over a needle. You're really just introducing the needle into the vessel and feeding the catheter. So it's a little bit different. I would say don't stress about it, and certainly don't add things onto your plate. It's not going to change things in the long term. But if you're passionate and you are really interested in phlebotomy and want to get some hands-on experience, I think that's a great option.
Thank you.
You're welcome.
Thank you. Okay. Would you mind talking? We have some questions about your residency program. People are wondering if you could talk more about that.
Sure. Like what in particular? That's like an hour talk in itself. Like any area or?
Yeah, maybe most interesting part you learned most from. Let's say that.
Oh, in residency. Okay. So I guess I'll kind of just cover it broadly. So like residency is your training in a specialty. So if people are from outside the US, I can't actually even draw a parallel. It's very different to what happens in the UK. I have friends that are equivalent of residents and medical students in the UK. So their system's very different, but basically we do medical school. It's generally, which is a specialized training. After your specialty, in certain areas, you can do a fellowship, which is a sub-specialized training. So we have some fellowships in emergency medicine. Surgery is very well known for having a ton of subspecialties or fellowships. Internal medicine has a lot. So to be a cardiologist is to be a internal medicine doctor who did a subspecialty in cardiology, which I believe is like 2 years extra. So for me, for emergency medicine, it's a 3-year program. I think to describe what it's like, we work a lot, we get paid very little, and your goal is to learn as much as you can in those 3 years. So I always work with a supervising doctor. The difference is in medical school, you're just kind of like playing doctor, you're gathering information and giving it to the doctor. Now I am a doctor, and when I go in the room, what I say matters. I put orders in, I write notes, and I make decisions, and I do procedures on my own. All of those things can happen on my own. Sometimes the attending will be there, sometimes they will not. It's kind of 3-year period where you get to go from knowing things as a med student to actually applying things as a doctor. And that's a big difference. So our residency, like I said, it's actually a very big program. It's across the city at some of the bigger level 1 trauma centers and some of the academic, we have an academic site as well. Some programs do that where you have multiple hospitals. Some it's just one hospital that you work at, just depends. That's something you look at when you apply for residency. So I think that's kind of like the general how residency works. You become a senior in emergency medicine your 2nd year. So then you start supervising junior residents, aka interns, and have a little bit more responsibility. But yeah, it's kind of like they show in movies, I guess. I didn't know much about like the stages, I guess, when I was a pre-med, but it's kind of weird. I'm a doctor, what I say goes, but I also have a boss who can override me, if that makes sense. I guess it'd kind of be like the store manager versus like the regional manager coming in and being like, we're going to change this. So it's kind of nice because you can learn and have that safety net of someone saying like, oh, did you think about this? We're going to do this instead. So.
Thank you. We also had a lot of people wondering like how COVID impacted your practice and your work in the ER, and maybe you could elaborate a little bit on that.
COVID sucks. If I could get a t-shirt, it would say COVID sucks. COVID really does suck. I don't really have a lot of like educational things to say. How it's affected, it's a location to location basis. It's sad, it's stressful. Thankfully, it is slightly better now than it was. Again, it just depends on your location for how it is. Sometimes we were seeing just COVID patients all the time. Sometimes we were seeing, almost no COVID patients. And so it's like ebbs and flows, and I'm vaccinated now, thankfully. But prior to that, there was a huge stressful component of, am I going to get sick? Am I going to get a PE and die like this girl that's younger than me that I saw last week? Is, all of those things. So it was very stressful. It really affected your training because you're seeing much less of what you'd normally see in the ER and just a lot more of COVID. A lot of people are staying home or, not coming in with the complaints that they normally would. So it definitely diluted the training. It definitely was stressful. It was hard on everyone emotionally and physically too. I mean, long hours and doing CPR in 2 gowns with gloves and a face shield and a full respirator. It's almost impossible to breathe. You're dripping it off and then go see another patient who's non-COVID and your scrubs are like absolutely drenched. So just, it was not, is not a fun experience. I really hope that, we're able to get vaccines out to the public quicker than we are, and that people are, continuing to stay safe and wear masks and things like that, because it has definitely changed what we do and what we see. And so, fingers crossed, I guess, for the future.
Yes, definitely. Do you have any advice for those of us who want to work specifically with minority populations in our career?
I would say it's important, find a medical school that supports your interest, and many of them will, but some are more plugged in with that mission than others. And then specifically find a residency that's really big on that. So one of our sites, one of the really nice things is we have a site that's in a very, very poor, low resource area of Chicago. And so all of the patients are an at-risk population, and you get a chance to really make a big difference. And these people are super sick. So, it's for that, I would say it's about finding the right residency.
We also had some people wondering if you did research in your undergrad or would recommend it.
Yeah, research is kind of the necessary evil. Be honest, I don't like research. I don't understand why you have to do, other than understanding the process, I don't understand why there's such an emphasis on research. I don't think it makes you a better doctor at all. I did a lot of research. Again, I, jumped through hoops just like everyone else back then. I didn't like necessarily have the confidence to just say like, I'm doing it my way. So I did, I worked in a nanobioscience lab, which at the time was super cutting edge on glaucoma. I worked on a cool, like, possible sepsis indicator device that came from like Iraq. So we were going on these dinners with these like military people that had developed it. So that was kind of a cool opportunity. I did what did I do? I think I did something else maybe. Oh, I did the neonatology stuff back even earlier, like the beginning of college. So I had a fair amount of research. I think, unfortunately, just do one thing. Get like one thing so you can say you did it and you have something to talk about.
Okay. Some other questions were, how stressful is it for you to be a doctor? I know you talked about that a little bit with burnout, but people were also wondering about just like general financial aspects as far as like student loans for going to med school, and how do you overcome these challenges with doing something that you're passionate about, but also knowing that it's definitely a draining career to have?
Yeah, it is. And I think truly, I try not to be too jaded. And again, if you don't already, follow my social media, because I think I do a good job of like giving a pretty real look there as to what it's like. It can be easy when I get going on a roll to sound pretty pessimistic, because it's true. Like, and it's like anyone, if you were in the middle of studying for a test and I asked you how you like college or how you like whatever phase you're at, you'd be like, it's not great. It's not good. All I do is study all day. Like, this sucks. And so my single day off out of 14 consecutive days or whatever, I was doing other work throughout the day. I have bills to pay. I have people to call during normal hours, because when I'm off, the world is sleeping. So you have like real life to keep up with, and you don't make a lot of money. And so you have to make your money go further and, be cautious about that stuff. And like, my girlfriend's in a different city, so we don't get to see each other. We have to maximize our time, and clumping your time together to try and do something like that gives you less days off in between. So it's definitely challenging. And I think asking me right now, like, how is it? How do you, like, is it stressful? Yeah, it's stressful. It's hard. I don't think anybody goes through residency and says like, wow, that was so easy. I really loved that. But it's important, and it's a special time, because you spend so much time in the hospital seeing so many patients with that oversight, that you get the chance to make mistakes and have them caught and see a lot of people and develop your techniques. So it's invaluable, and I think you just have to take the good with the bad and understand that it's a temporary thing. Anyone can put their head down and get stuff done for a set period of time. People have done it before you, and you'll do it. So that's kind of the mindset I go through it with. But it can be stressful.
Thank you. Would you mind walking us through what a typical day is like for you in the hospital right now?
Sure. Yeah. So emergency medicine is different than all other specialties. Our life, like I said, is a lot better. So tomorrow, for example, I work from 8 to 6. So when I'm feeling really motivated, which is not today, I will get up at 4:45 and go to the gym when it opens. I'll work out and then eat and all of that stuff, and shower and drive to work. It takes me about 25 minutes to get there. Get to work a little bit early, clean off my station, wipe everything down, get signed in. There's like a whole process. I got to get a phone and all this stuff. And obviously I'm in the ER. So once I become an available provider, I can start. I'll be picking up patients and kind of start my day. Once I'm there, it's not like a ton of exciting stuff to share. I just kind of like see patients as much as I can, staying on top of my notes. I eat while I'm there. You don't actually like take a lunch. There's no like, you don't get a break. That's how my girlfriend is in. We don't get breaks in the ER, but we have a better schedule as a whole. So, I eat while I'm at my computer charting or whatever it is, go to all the traumas, go to whatever it is I need to do, see all the patients. And then at the end of the day, it's only 10 hours only. It's like pretty exhausting. So about 1 hour to like an hour and 15 minutes before the end. So I'll end at 6 tomorrow. So about 4:45, I'll stop seeing new patients, and I'll start to try and get my patients that I already have wrapped up, get their notes done, get them either admitted to the hospital or sent home, whatever it is, so that I don't have to hand off as many patients to the next doctor coming in. So I'll do that. Then I'll come home, try and make some food. And obviously, again, you guys know I have a huge social media business. And so I try to spend some time doing that. And whether it's making content, doing an interview like this, like a shadowing event, I have the TikToks to make, the YouTubes, all of that stuff. So dive a lot of energy into that. And then always try and make sure I have some personal time to, I'm on a different time zone from my girlfriend, but I call her, so I can talk to her and maybe talk to family, whoever else I can in the evening. And occasionally try to study. I probably need to study more. But I do have boards coming up, so I've been pretty good lately, but I'll get some studying in there. So it's pretty jam-packed.
Yeah, definitely. Expanding a little bit on that, can you touch on relationships in med school, whether it be friendships, familial, romantic, as having so many responsibilities and just being so overwhelmed and busy and dedicated to your classes? What advice do you have for students?
Yeah. So everything in life is a sacrifice. Remember that. One of the really good medical educators describes life as like a battery, and you only have so much energy. You need to recharge that battery. Other people can drain your battery. You can drain your battery, so on and so forth. So you need to find out the things that give you energy and the things that take energy away, and you need to balance those. So talking to your grandmother, even though she may love you very much, may be draining, because maybe you have to repeat yourself many times, and maybe she asks, the same question over and over, because I don't know, I'm making this up. Maybe she has like a memory condition, but she keeps asking and asking. And so if you're already really stressed and you have that conversation on a day where you're stressed, you're going to drain your battery. So you need to prioritize and schedule things. So if you know that talking to your best friend brings you up, then at the end of your study day, put that phone call, because you're not going to be checking your phone all day, trying to text them, do whatever. But you're going to say, hey, I'm going to reward myself with doing really well today by having that phone call. And on the flip side of that, if let's say, I'm not picking on this imaginary grandma, but say that phone call is going to be stressful for you, or it's going to make you upset. Do that first before, let's say, you go to the gym. So you can do that. You can go do something else and clear your head, and then come back and get to work. So it's kind of about compartmentalizing and scheduling things out. Relationships with romantic partners, I will probably steer clear of it, mostly because this is recorded, but medical school is a lot like high school, except for adults. It's a little bit ridiculous. Actually, like college, I guess. It's more like college. There can be pretty ridiculous parties, and people make some interesting decisions. So there's that side, if you want to do that. There's also like a whole group of people that are married with kids and acting like normal adults, but with very high stress comes very interesting choices for some people. So there's that component there. There are people who meet their significant other. Again, it's what you make of it and what you choose to invest your time and energy into. So I think that kind of covers friendship, family, and romantics. Does that work?
Yes, I think so. Okay, we'll do one more question. Okay. So do you have any advice for international students who are looking to go to med school in the US, and whether that be them coming over directly from their undergrad into the US, or just coming from already having undergraduate experience in the US, but still applying to med school, like how to get over those hurdles?
Yeah, I'll be totally honest with this one. I get this question all the time on social media. Unfortunately, I don't. I have no connections. I have no way to make any connections for that. I know it is a very different process in terms of obtaining like a visa for long-term stay and for studying and getting a residency. And there is a whole nother world of knowledge about trying to come to the US for a residency, and only certain programs will support visas for that. So I'll have to sidestep that one. I really don't know much, and I'm not much help in that area.
No, that's okay. Be honest with what we know and what we don't know, and what we can help with what we can't. Then I guess, do you have any just like final advice in terms of what you think people should know going into med school, and just going through other undergraduates as pre-health students?
I think find something that you're passionate about. I've said it. I'll say it again. You know, find what you're passionate about and what makes you do this crazy long experience. Find out what keeps you going, because you need to hang on to that to get you through this. And that's going to give you the energy and the motivation to do well by your patients and by yourself. And I'm sure most of you probably already do, but if you don't, please follow me on Instagram, on TikTok. We have the YouTube. You can subscribe there. You know, I tend to think I'm very passionate about what I do with the education. Obviously, I've done extra training in education, and so I think we offer a really unique opportunity where you can not only you know, get a look inside my life, like from Instagram, but there's some very high level education on there that's done in very basic language. So let's say one of the new things, we're partnered with Butterfly Ultrasound. So if you wanted to learn ultrasound, I now have that content on my Instagram. It's on YouTube as well. I just, like I said, put up a study algorithm today, and we're doing some more fun videos this year on YouTube. So it should be a little bit more fun. TikTok has a ton of fun stuff, but also procedural stuff, learning some of the instruments and things that I'm able to get that are like considered dirty. Yes, exactly. See the MedLife. Thank you, Amy. It looks like I put it down there. So it's See the MedLife on Instagram and on TikTok, and on YouTube, it is just the MedLife. So yeah, I think follow me there. I do my best to try and answer my DMs. To be honest, I fall behind. So I'll try. But thank you all for listening. I know this was a long time. I really hope that this was helpful for all of you. Like I said, if you have any questions, just try and title the first line of your message like something of substance, and not hey. Hey gets deleted really quickly when you have, you know, a lot of inboxes messages. So thank you everyone though for hanging out. I appreciate it, and I hope this was helpful.
Wonderful. Great. Thank you so much, Dr. Goodkoff, for spending your evening with us today. We know you're super busy, and we just really appreciate you taking the time out of your day to kind of educate the next generation of healthcare professionals. For all of my students, I do have some important information regarding the post-shadowing assessment that you guys will be taking today. If you are interested in receiving a certificate that verifies your virtual shadowing hours. So we do recommend, since there are a lot of students joining us today, that you try to stagger taking the post-shadowing assessment. You guys can go ahead and try it once it opens at 5:30 Pacific Standard Time. It will be opened. But if you do get any errors, we have accounted for this by giving you guys 2 tries. So if something happens to the website and it shuts down because we don't have enough money to keep it up for all of the students that we currently have going, then you guys can still have a second try at getting the post-shadowing assessment. And we'd recommend you take it a little bit later. The video will be uploaded to our website and YouTube channel if you need a refresher. But we hope you guys took great notes, and we hope you really benefited from today's virtual shadowing session. So a couple things, and I will go ahead and tell you guys how to take the post-shadowing assessment. Just take a moment today and kind of reflect on today's session. You know, why are you here? What resonated with you? What are your key takeaways from today? While these are not due to us to make sure that you guys were joining, you know, as we talked about today, you're going to be writing your personal statement. You're going to be trying to apply to different programs. Really figure out, you know, what's your passion? Why are you even here today? You know, what is fueling you? What are you inspired by? And so go ahead and just write that down. If you want to keep it to yourself, you're more than welcome to. If you are looking to share it with the rest of the world, you can get published on the Pre-Health Shadowing website, prehealthshadowing.com/blog submissions. You can submit your reflection from today. You can also submit articles, reviews, and success stories for the opportunity to be submitted and published on our website. So you guys can put this on your applications, your CVs, your resumes, your LinkedIn. If you guys are interested in getting some more information about this, we do have rubrics available upon request. You can email us at info@prehealthshadowing.com. If you guys are interested in joining our student team, we are a student-based, student-led nonprofit organization. You can hop on board. We are a 100% remote team where you can, you know, excel in some leadership opportunities, gain professional experience, also while building on your personal and academic growth as well. If you guys are interested in joining our student team, you can apply on our website. While this is a leadership position and is a commitment, we do have opportunities for students who are super busy right now, because as pre-health students, we know you are busy. If you are still looking to get involved and don't have a specific set time every week that you can help out, you guys are more than welcome to work asynchronously with pre-health shadowing and help us with student outreach and professional nominations. We also do have hands-on projects for volunteers and give the opportunity for volunteers to lead their own projects. So if you guys are interested in potentially leading your own initiative within pre-health shadowing, you are more than welcome. You can sign up on our website, prehealthshadowing.com. And yeah, feel free to email us at volunteers@prehealthshadowing if you guys have any questions. Alrighty, this is a different QR code than I presented to you at the beginning of today's virtual shadowing session. This is actually to join our fundraising team. So this is to send it out to various people that you have connections to. And you can actually get virtual volunteering hours for this. It's super easy. You just send out our GoFundMe link. And we really are working to fight against inequity in health education and promote diversity in the various fields. And so by you guys helping us money, we can make these opportunities available for people who do not generally have these opportunities. Thank you, guys. Back to our mentorship networking weekend on February 19 to 21. You have the opportunity to meet with up to 6 professionals. And so from today's raffle, I would like to announce the winner from today's raffle. Our winner is Karina Swami. So congratulations, you have just won an RSVP invitation to our mentorship networking event. Please email prehealthshadowing at info@prehealthshadowing.com with your contact information so that we can send you the RSVP. Be sure to tag us in your posts whenever you do anything cool. We'd love to hear about it at prehealthshadowing. You can also use the hashtag prehealthshadowing. You could potentially get reposted as a featured student on our social media. We are active on TikTok, Instagram, Facebook, and Twitter. Feel free, if you guys are also interested in making content, you guys can do so as volunteers and get volunteering hours for making Twitter and TikToks. Alrighty, some upcoming shadowing sessions for you guys. We have a full week of shadowing sessions. Here are the next 2 days. You guys can sign up on our website, prehealthshadowing.com/sessions. And finally, to get the certificate that verifies your virtual shadowing hours with us today, you are going to go to our website and you're going to find Dr. Goodcoff's picture. You can go ahead and click on it. It'll take you to his speaker profile. Once you're there, you click free, take this course, and you will have 30 minutes and 2 tries to get over a 70% on the post-shadowing assessment. Once you do so, you can click Finish Course. You'll then be able to download your certificate immediately, and you'll also be able to find it at any time in your profile under the Certificates tab. The quizzes are open indefinitely until further notice, and so if you guys are postponing it, want to do it a little bit later, we will upload the video onto our YouTube and website, and so you guys can check that out. Thank you so much for joining us today for another virtual shadowing session. We will be around for the rest of the week. And thank you guys. This is the end of our virtual shadowing session, and I invite you to disconnect from the call. Have a wonderful evening, guys. Happy Monday. Thank you. And whoever's recording, you guys can go ahead and stop the recording.